Every week, a patient walks into my clinic and tells me the same thing. My last therapist told me, this is as good as it gets. They still have a quad lag, they still have a limp, they still don't feel confident with cutting or jumping, and they were told just to accept it because their insurance ran out or it's been 12 months. So they're good enough. If you're a clinician and you've ever said those words, I'm calling you out. You haven't achieved a patient's full potential. You've reached some limit of a framework that you've been trained upon, but that's not your fault. Most rehab follows a predictable, dangerous pattern. Pain goes down, time goes by, someone gets cleared without a single objective metric to defend that decision. We can't keep doing rehab this way. Hi, I'm Dr. Leon Knight. I'm a physical therapist and founder of the Performance Doc. I built the PRO method because I refuse to let average be the clinical standard. In 2009, I tore my ACL while playing basketball, and I received what I now call average physical therapy. When I graduated PT school from New York Medical College in 2015, I went into the field with the same struggles that you may have. No guidance, no confidence in progressions, and a constant fear that I was going to mess up the surgeon's work. I spent years hating my inconsistent results until I realized the problem. We are treating individuals with a one-size-fits-all approach. Do you know that 56% of physical therapists use manual muscle testing as their only strength measure? That is a participation trophy, not a clinical metric. My framework stems from my belief that if you can't defend a return to play decision with data, then you shouldn't be making it. I progress my patients through 7 phases, and they can't move on unless they meet the objective measurable criteria in each phase. Phase 1 is maximum protection. The patient is fresh out of ACL surgery and has to limit movement, control swelling, protect the repair, and avoid stressing the healing tissue. We don't even talk about walking without crutches until you've earned it. The value here is securing the foundation. You don't pass until you have 0 to 100 degrees of active range of motion and can perform a straight leg raise without a lag. If you can't stabilize your own leg, you have no business putting weight on it. Phase 2 is protection. The healing has started, but we still have to be very careful. This is where range of motion, quad recruitment, and normalizing the gait pattern take priority, while still controlling swelling and pain. To pass, you need 0 to 125 degrees of range of motion, but more importantly, you need to prove stability with a 30-second single leg stance and 30 consecutive straight leg raises without a lag. Phase 3, functional restoration, where we focus on restoring the patient to full, pain-free movement and strength required for daily activities. We don't move on to the next phase until range of motion is 95% symmetrical and you can complete the wide balance reach at 80% of your uninvolved leg without using a hip strategy to cheat the movement. All right, here we're looking for 95% of the uninvolved leg. In this case, her right knee is the knee that had the surgery. So right now I have both of her legs in extension, both of them with the same prop underneath. And I'm just looking to see, are they for the most part the same? She has a little bit more on this side, but it's still within 95%. Next piece, I'm gonna have them bend their knees as much as they can. And again, you can see they're basically the same. You only have to bring the goniometry out or goniometer out if you're looking at something like this, right? Because then now I have to measure and then do my math and see if it's within 95%. If it's not within 95% of the uninvolved side, which would be her left, then they will fail this particular part of the criteria, and you will know that you have to make sure that this becomes a priority in order to pass to the next phase. All right, next up is our wide balance assessment. Here we're looking for 80% of the uninvolved side, okay? So in this case, my right leg is gonna be the surgical leg. It needs to score within 80% of my left leg. We're gonna do 3 different movements. So what we'll do is we'll do the first one, which is forward. We're looking at that ability to accept the weight forward or anteriorly, using the quad mainly. And what you'll see is I want them to reach with their toe and come back in a controlled manner. I won't count this because now they're actually resting on the balance mat, or I won't count this, right, when they're trying to regroup. They get 5 attempts to get 3 successful attempts, okay? And then you're gonna average those 3 and compare them to the other side. So that's the forward one. The next one would be this plane of motion, okay? And the last one is similar to a curtsy.
All right, so this is a good test to gain qualitative and quantitative. Quantitative is the average score for each movement, right? But qualitative would be how well, what's the quality of it? How well are they performing it? So for instance, if someone does the forward one like this, so all their weight's back, I don't necessarily pass that. Or if I see with this particular motion, they're just hinging at the hip as opposed to bending the knee, they're using a hip strategy and offloading the knee. So I wouldn't necessarily pass that. I may try to cue them and ask them to redo it. And if they cannot redo it, then I know that's something I have to work on, and I would not pass them with this particular test.
Phase 4, progressive overload. This is when we gradually increase the intensity, load, and complexities of movement so a patient can safely rebuild strength, endurance, and resilience beyond basic function. This is where traditional rehab fails the athlete by underdosing strength. We don't progress until the math is undeniable. 25 single leg squats to a 20-inch box, 25 single leg bridges on a bench. If they can't hit those numbers, they aren't ready for impact. Phase 5, intro to impact. This is where we reintroduce jumping, landing, and higher impact activities. We don't jog at week 12, and we don't touch a treadmill until you can perform 12 repetitions at 70% of your novice norms for goblet squat, lunges, and RDLs. And you demonstrate less than a 30% quad deficit with isometric testing.
So our goblet squat test, we have to use a certain amount of weight, and the way we find that weight is going to be based off of our body weight. In this particular case, the criteria to pass the goblet squat, I have to use 70% of the novice norms that you can find on strengthlevel.com. And for me, it's going to be 40 pounds. I have to do 12 repetitions and make sure I break parallel. They have to hold the weight away from the chest. It can't rest on the chest. All right. Feet are going to be shoulder width apart, and they can toe out a little bit. And you're looking for symmetrical weight bearing the entire time for all 12 reps. The RDL test. What you're going to do is find the values that you need based on the patient's body weight. And remember, you're going to use 2 dumbbells. That's the weight that you find on the strengthlevel.com will be for the dumbbell in each hand. And you're going to do 12 repetitions of the novice norms, 70% of the novice norm. You want them to be able to go down to mid-shin and return back up without a hitch and with a symmetrical pattern. Our forward lunge test, I'm a stickler for the forward lunge in terms of form and technique. So I want to make sure I go over what's important. Before I do that, make sure that they do both sides. And the reason why for both sides is because there's an eccentric component when the surgical leg, in this case, let's say if it was my right leg, when it's behind me, there's an eccentric component that I must be able to tolerate and demonstrate a certain level of control and strength. Oftentimes you'll see people do this. So they'll bend the knee so far forward so they're not eccentrically loading it, and I don't pass that, okay? In addition, when the surgical leg is in front, we're looking for full weight acceptance and that knee translating towards that toe, okay? We don't pass this, right? And we don't pass a partial, okay? 12 repetition, the weight that I had was 40 pounds based on my body weight.
Phase 6, deceleration. Most clinicians skip this step. They love to test go, but they never test the brakes. Before we initiate cutting, we require less than 20% quad strength deficit and less than 20% deficit in deceleration RFD on a force plate. If they can't stop, they shouldn't be allowed to start. Phase 7, return to sport. The final phase where a patient is progressively cleared to resume sport-specific activities. The data has to show 95% or greater LSI on both the single and triple hop tests, less than 10% quad deficit with isometric testing, and an ACL RSI score of 80% or greater to prove their head is as ready as their knee. Even then, they stay non-contact until month 9. As clinicians, our authority comes from outcomes. If you are clearing patients based on a calendar, then you are a liability to that patient. When a patient hears, "This is as good as it gets," it's a sign that the system have given up on them. It means the strength was underdosed and the decisions were made based on a clock and not a metric. So stop being a clock clinician and join my mission in order to fix the system. If you're tired of using physician-written protocols that only cover the safety basics and ready to start using a system that is built on high performance, you need to raise your bar. Stop guessing and start testing.